for my Viva Voce, we're looking at the case of Mia. Mia is a primoparous woman who came in spontaneous labour with a low-risk pregnancy. The case picks up at 14:15 hours as Mia began pushing, with the VE determining that her cervix was fully dilated with the presenting part at +1 station. Mia was pushing for an hour and 20 minutes with very slow descent of the head. As previously mentioned in her case, she was having a syntocinon infusion, 10 units of syntocinon, as an augmentation due to her incoordinate contractions. For the sake of the case, the synto was running at 90 mils an hour. She was contracting 4 in 10. Due to the syntocinon augmentation, a continuous CTG was being conducted, as the syntocinon augmentation is an indication for continuous electronic fetal monitoring. For the sake of the case, the CTG was showing early decelerations associated with second stage labour, and the fetal heart rate baseline was 147. At 15:35 hours, the baby's head was born. Not much of the neck was visualised, and turtlenecking was seen. Upon gentle downward traction, the baby's body was not born, and there was struggle with restitution. Therefore, a diagnosis of shoulder dystocia was made. At the diagnosis, the emergency buzzer was pressed. In response, midwives come, and it is my job as the primary care provider to delegate. So upon response, I would delegate one midwife to start documenting. I'd want them to document when we started pushing, when the shoulder dystocia was diagnosed, and the following events. I'd get another midwife to place a call for a neonatal emergency in whatever room I was in. Shoulder dystocia places a really high risk for the baby needing neonatal resuscitation, so we want to make sure that the NICU team are aware and are present. I'd also get them to pull in the neonatal resuscitator in preparation and set that up. I'd get another midwife then to assist me with the shoulder dystocia manoeuvres to try and relieve the dystocia and birth the baby. The first manoeuvre that I would do is placing the woman into McRoberts. Most shoulder dystocias are alleviated when the woman is moved to McRoberts. McRoberts involves putting the woman's knees to her chest to try and free the shoulder. At this point, I would tell Mia that she doesn't need to push anymore, and I would apply gentle downward traction to the head for 30 seconds. If the shoulder is not freed with this maneuver, I'd then move on to the second maneuver, Rubens 1. Rubens 1 involves suprapubic pressure, so finding the posterior of the anterior shoulder and applying suprapubic pressure in a rocking motion to try and free that shoulder. Again, this maneuver is only performed for 30 seconds in order to expedite the birth and ensure that the baby does not experience severe distress resulting in hypoxic ischemic encephalopathy. If Rubens 1 is unsuccessful, I would then get the ONG to evaluate if the woman needed an episiotomy. The episiotomy does not help to free the shoulder, however it doesn't decrease her risk of a third-degree tear, and it does assist in the following enter manoeuvres. In Mia's case, the ONG did perform an episiotomy, and then the following enter manoeuvres were performed. So Rubens 2 involves placing 2 fingers into the vagina at the posterior of the anterior shoulder and applying pressure to try and free the shoulder from the symphysis pubis. This is only performed for 30 seconds. If this is unsuccessful, another hand is inserted to perform the wood screw. The wood screw places this hand at the anterior of the posterior, while the posterior of the anterior remains, and pressure is performed in this kind of direction. Again, only for 30 seconds. If this is unsuccessful, we then move on to the reverse wood screw. Leaving both hands at the vagina, the hands do not get removed, we switch to place one hand at the posterior of the posterior shoulder and the anterior of the anterior shoulder to apply pressure in a similar fashion, just in the opposite direction to try and free the shoulder this way. Again, if it is unsuccessful, we cease after 30 seconds. The next maneuver is the removal of the posterior arm. This involves leaving the hands in the vagina, reaching in to find the baby's elbow, flexing their arm and sweeping it across the face and out the vagina to decrease the diameter that has to be born and birth the baby. In Mia's case, this was successful and the baby was born. If this was unsuccessful, the next maneuver is to roll the woman onto her hands and knees in the McRoberts position with her knees to her chest and repeat the enter maneuvers. If this is unsuccessful, the case then gets passed on to the ONG, as this moves out of the scope of the midwife. Some of the maneuvers that they may perform are the symphysiotomy or the Zaffanelli's maneuver. This is out of the scope of the midwife's practice, and therefore the midwife is just there to support the woman and the obstetrician in what they need. In Mia's case, the baby was born upon the removal of the posterior arm. As previously mentioned and predicted, the baby was born with a low APGAR of 6, and then 8 at 5 minutes and 9 at 10 minutes. As per local policy and the NICU reg, delayed cord clamping should be attended in order to assist the baby with their transition to extrauterine life and oxygenation. While there's delayed cord clamping, I would stimulate the baby tactilely to try and assist in their breathing. Following this, the baby would get passed on to the NICU registrar, who is the most senior, to perform the resuscitation. Another risk of shoulder dystocia is postpartum hemorrhage. Upon the birth of the baby, 10 units of syntocinon would be administered intramuscularly into the thigh of the mother in order to reduce the risk. In Mia's case, once the placenta was born, an excess of blood loss was noticed. The estimate was 400 mils, and because it was a high estimate, the blueies were changed and weighed, and the blood loss was noted at 450 mils. Because shoulder dystocia is such a high risk factor for postpartum hemorrhage, prophylactic measures would be put in place as per the ONG and also the midwife's intuition. Prophylactic measures include the insertion of an indwelling catheter, a 40-unit infusion of syntocinon in 1,000 mils of Hartmann's, the suturing of the perineal trauma, and also fundal massage. In Mia's case, the fundal massage found the uterus to be boggy and therefore was continued until it was firm and central. The perineum was sutured by the ONG to eliminate genital tract trauma as one of the causes of the postpartum hemorrhage. The 40 units of syntocinon was running at 250 mils an hour, and the IDC was draining clear/yellow urine. Following the suturing of the perineum, the fundus was then found to be firm and central, and there was no further blood loss. Total blood loss was then weighed to be 560 mils an hour. Mia would then be debriefed about the entire scenario. Any questions she had would be answered, and as soon as possible, we would get Mia to move over and visit her baby in NICU, hopefully for a breastfeed. The entire situation will be documented as attached to this Viva Voce, with every single time and maneuver documented, with the person who performs the maneuver and the result. Where possible, the fetal heart rate should be documented underneath each maneuver, and the cord gases taken from the umbilical cord once the baby was born should be taken and recorded also due to the fetal distress caused by the shoulder dystocia.